Hello listeners, welcome back to Desert Docs, a junior doctor's guide to Central Australia. Today we've got Dr. Anosh, dual cardiology and gen med advanced trainee, once again to talk about rheumatic heart disease. Welcome back, Anosh.
Thanks so much, Indi. I'm excited to talk about acute rheumatic fever and rheumatic heart disease in Central Australia.
I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country, and that we work on their stolen lands. You may have heard about rheumatic heart disease during medical school. However, it does remain quite rare in mainstream Australia. Due to social determinants of health and the downstream effects of colonisation, rheumatic heart disease disproportionately affects Indigenous Australians, particularly adolescents and young adults. And we see it all the time in Alice Springs. Today we'll be covering acute rheumatic fever and rheumatic heart disease. This is quite a dense topic, but please note there are very helpful guidelines and even an app called ARF RHD Guidelines, which you can refer to while you listen to the podcast. So Anosh, can you give us a quick recap on the pathophysiology of rheumatic heart disease?
Yes, rheumatic heart disease, as you said, Indi, is a disease that we don't obviously see in most of Australia, but unfortunately in the Northern Territory, due to multifactorial reasons, which I'll talk about later, does affect the Central Australian population as well as top end disproportionately in the Indigenous population. In terms of the pathophysiology of rheumatic heart disease, it all starts off with a group A beta hemolytic strep infection, and this can be in the context of a pharyngitis, or more commonly what we've been seeing recently is skin and soft tissue infections with group A strep leading to acute rheumatic fever. In terms of the pharyngitis presentation, they can present to primary healthcare settings or emergency medicine settings with pain, difficulty swallowing or dysphagia, decreased oral intake, fevers, croaky voice, enlarged erythematous tonsils with exudate, and enlarged tender cervical lymphadenopathy. The strep A associated with throat infections accounts for up to 37% of cases, and we can talk about this more in later, but ideally for this population, we need to think about primary prevention, and the key is giving early antibiotic therapy with intramuscular benzathine, benzylpenicillin G. With regards to the skin and soft tissue infections, people can have a skin break in the context of scabies, impetigo, insect bites, tinea, lice, just to name a few, and as a result, strep A can be associated crazily up to 82% of times in these impetigo episodes. So it's important when we see people, and especially young children, where it is disproportionately affecting especially the 5 to 14-year-olds, females more than males, we do need to think about not only primary prevention when they get potentially group A strep infection, but also primordial prevention to try and minimize group A strep from causing skin, soft tissue, and pharyngeal infections in the first place. A little bit about the pathophysiology. The group A beta hemolytic strep basically does a autoimmune molecular mimicry process where it can mimic the M proteins in the heart, especially around the valves, but also the M proteins in the basal ganglia in the brain, which gives rise to synonyms chorea because of the basal ganglia being important for the movement center of the brain. So it's the molecular mimicry, the recurrent infections, and this ongoing autoimmune process that leads to immunological and inflammatory proteins and deposition in joints, the heart, the brain, for example, that lead to the manifestations of acute rheumatic fever, and then recurrent episodes of acute rheumatic fever, and especially with issues with regards to adherence to the LA bicillin that lead to, unfortunately, development of rheumatic heart disease, which is where you have significant valvular problems, regurgitation and stenosis, and then we can talk about the complications of that later on.
With regards to the group A streptococci, is it any group A strep that can cause this, or are there particular strains that are more likely to be pathogenic and cause this pathophysiology?
That's a good question. So yeah, we talk about the group A beta hemolytic strain is probably the most likely and virulent in terms of the etiology for causing acute rheumatic fever. There are a couple of other strains and whatnot. And so in general, when we have a group A strep infection, especially when it comes, as we talked about, from a pharyngeal or a skin source perspective, we do tend to be on the side of caution and have a lower threshold unless contraindicated to give LA bicillin. And especially in Northern Territory and other endemic parts of Australia where rheumatic heart disease and acute rheumatic fever is very high in terms of its incidence and prevalence, there are other strains, but the management is still the same.
Got it. So what are the different clinical presentations of ARF or acute rheumatic fever? You did allude to them before, but what does that look like and what are the different investigations of choice?
The presentations of acute rheumatic fever can not only be distinct in terms of how they present, but it can also be quite subtle. And just before I forget, the reason why we differentiate between the different entities of definite, probable, and possible diagnosis of acute rheumatic fever is to not miss the diagnosis. Because if we miss the diagnosis, even in someone who potentially might have a lower clinical threshold of suspicion, this could be significant in terms of its progression from mild or subclinical disease to moderate or severe disease, and as a result, end organ complications from severe rheumatic heart disease. In terms of the presentations, you very well may have recalled from your medical school learning about what we call the Jones criteria. And just as a side note, the way I remembered it for medical school and for internship for that matter is basically to use the Jones criteria as the mnemonic. So J stands for joints. So that can be representative of an arthralgia, which is basically sort of painful joints without a synovitis component of erythema, warmth. And it's normally a migratory process and it can be asymmetric. It can also be a aseptic monoarthritis or a polyarthralgia as well. So that's the J. O is what I remembered as an O-shaped heart, which can be representative of carditis. And that can be effects on the endocardium, myocardium, or the pericardium, which may cause incompetence or regurgitation, but over time can lead to calcification and commissural issues, which may progress and obviously transition the change to rheumatic heart disease. N is basically your subcutaneous nodules. So these are normally painless. They're not that common. They're relatively rare. But if they are present, then they're quite pathognomonic of potentially that person having acute rheumatic fever. E, similar to N, is erythema marginatum, and again is not common, is relatively rare. And they're not painful, they're not itchy, they're normally seen on the trunk and the proximal surfaces. But again, if they are present and you do recognize them, they are relatively pathognomonic of someone having acute rheumatic fever compared to sort of other differentials. And S is synonyms chorea. And that's, as I talked about before, the autoimmune molecular mimicry of the M protein at the basal ganglia, where people can present from mild manifestations of just a mild involuntary tremor that's asymmetric to significant presentations with seizures and debilitating symptoms that may even require anticonvulsants. Again, you don't need to remember any of this. It's just a framework for you to have as a mnemonic. And there is a wonderful app, as Indi talked about, that does allude to this, and that's the RHD app. And you've also obviously got the 2020 Rheumatic Heart Disease and Acute Rheumatic Fever Guidelines, which is a fantastic read and something that we use all the time, especially in regards to duration of management with L-A bicillin, monitoring, follow-up, and when we need to do echocardiograms, for example, with rheumatic heart disease patients. Going back to acute rheumatic fever, so those are the symptoms and signs that someone may present with, but that's not enough to make the diagnosis. You need not only additional serological evidence of a group A streptococcal infection, but you also need biochemical evidence of recent streptococcal infection and inflammatory activity. And this is where basically the major and minor criteria for Jones comes from. With regards to serology, we look at the anti-streptolysin O titers and the anti-DNase B titers. And again, you don't need to memorize values. There's tables for this as the values do change with age. The anti-streptolysin O titers can rise within the first 1 to 2 weeks, and then they max out at the 3 to 6 week mark. But you do need to be wary that when we send these tests, they go out to Darwin and it takes a lot of time for the results to come back, and therefore clinical suspicion in addition to other investigation results may be sufficient for us to work out whether the diagnosis of ARF is a definite, possible, or probable. In terms of anti-DNase B, it takes up 6 to 8 weeks to max out in terms of the result and the titer level. Swabs are very helpful if we do obviously have evidence of strep pharyngitis, and a positive throat culture with the blue top swab and sending that off for a bacterial swab is something that is very, very helpful. And ideally, this should be done before we administer the L-A bicillin. Inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate are part of your minor criteria. And again, you don't need to remember values, but these are things that we look at in terms of the minor criteria. And you've got to remember that there are a lot of causes for an elevated CRP or ESR. So a lot of these do need to be taken in conjunction with other biochemical inflammatory marker findings as well as clinical findings. The ECG is important, especially if you don't have evidence of carditis in your major criteria, to look at the PR interval, and PR prolongation can also be a minor criteria. So as I said, there's a major and the minor criteria, just to summarize, and that's a combination of those features we talked about with Jones, so joint issues with arthralgia, aseptic monoarthritis, polyarthralgia, carditis or valvulitis, subcutaneous nodules, erythema marginatum, and Sydenham's chorea. And then the minor criteria is a combination of a temperature with fevers up to 38. And with these cases, you have to be also careful and think about taking blood cultures as well. Monoarthralgia is also a minor criteria, but that's only if you don't have the major criteria of aseptic monoarthritis or polyarthralgia. And then the ESR or CRP being above 30, and finally the prolonged PR on the ECG, but again, only if you don't have the major criteria of carditis. And just very quickly, touching upon the definitions, as I said, it's important to not miss the diagnosis, and therefore they've classified it in the latest guidelines into definite, probable, and possible acute rheumatic fever. So just to recap, with definite acute rheumatic fever, that's where you have two major manifestations, plus evidence of a preceding strep A infection, or Sydenham's chorea, or one major and two minor with evidence of preceding strep A infection. Probable is basically one major or one minor criteria with no evidence of preceding strep A infection, and possible is defined as uncertain. So like I said, I know it sounds like there's a lot, and there is a lot, but it's important to realize that you can always refer to the guidelines or the app when you're coming up. But the importance is having a low threshold, especially in a place like Central Australia, for picking up these diagnoses, as it can have manifestations not only in terms of management, but also in terms of progression if left untreated.
One learning point that I have from, again, in the emergency department is I had a young child, about 2 years old, with fevers and pointing to a sore ankle. The learning point from this was that I was going down the ARF pathway and thinking that the sore ankle was an arthralgia rather than arthritis. So arthralgias have heat and swelling and clinically look like a sore joint, whereas arthritis will just be a sore joint without clinical signs. So that was a mistake I made in just calling something an arthralgia that was actually an arthritis, and that meant that kid was actually spared from getting a long duration of 3 to 4 weekly doses of L-A Bicillin. Moving on from that, just in terms of talking about healthcare response to suspected ARF, you might encounter acute rheumatic fever in the primary care location or in the hospital in an emergency department like I did. Who's best to talk to next?
Yeah, that's a good question. I guess it depends on the age of the patient, as you touched upon briefly with that sort of excellent clinical learning experience that you had. So if they're obviously quite young and they fulfill under the pediatric age bracket, then you refer to the pediatric registrar for an admission, especially if they're already in hospital. And again, if you're in the primary healthcare setting and you're a general practitioner, then, you know, if you have any questions whatsoever, I'm sure the pediatric team would be more than happy to have a call, because obviously early diagnosis is crucial. In terms of an adult patient with concerns for acute rheumatic fever, it could be picked up in a combination of settings in the community, in primary healthcare, in the emergency department, or even in the wards. And so we're always happy if they're in hospital for the cardiology team to be contacted. And the reason for this is not only potentially to necessitate an admission, but it's also for us to get in touch with our wonderful rheumatic heart disease coordinator, Melissa. And Melissa is someone who works around the clock tirelessly and registers every single patient of acute rheumatic fever and rheumatic heart disease to our rheumatic heart disease registry. And she also keeps us up to date with who needs what, who is at risk in terms of missed doses and monitoring in terms of echocardiograms, and works really as an adjunct resource for our RHD guidelines and RHD app. And it's important not only just to think about diagnosing, but also following up these patients, and that's where we need the multidisciplinary team. There is a database at Alice Springs Hospital which records the amount of L-A Bicillin doses as well as adherence and the days at risk. We usually give it every 3 to 4 weeks, so every 21 to 28 days. Now, these are not the most desirable of medications, and they're not tablets. They are very painful injections, we have to note. We do see people, as a result, understandably not being adherent with it for a longer period of time. But we give it either in the gluteus or the vastus lateralis, but we don't give it in the shoulder. There are other options such as phenoxymethylpenicillin, but this is a twice daily dose and it's nowhere as good as the LA Bicillin, which is the preferred in terms of its effect. And there has been clinical evidence for a long period of time in the literature about the efficacy of this. In terms of people who have penicillin allergies, we can also consider giving erythromycin. However, if there's any uncertainty about which agent to give and what to do, the cardiology teams and the general medicine teams, for that matter, are very happy to be contacted. Management of acute rheumatic fever is not just about diagnosis, registering them and following them up, but we also need to think about other complicating factors and other issues that may be going on. People with acute rheumatic fever are at risk, for example, of infective endocarditis or other systemic superinfections. And as a result, you may not only need an echocardiogram then and there to help diagnose acute rheumatic fever, potentially pick up rheumatic heart disease, which I'll talk about shortly, but also rule out infective endocarditis. Analgesia is important, and as per the guidelines, they actually recommend paracetamol for arthralgia if we can get away with that, but it can be very debilitating and really have functional limitations. And yes, nonsteroidals are very helpful, but there is some caution from the guidelines about that masking the actual pain and therefore presentation of a classic acute rheumatic fever patient. So something just to keep in the back of our mind. Antipyretics, especially with a temperature above 38 degrees, is something that should be helpful, but we do need to think about considering blood cultures if required, in addition to our septic screen of a swab of the pharynx, as well as any skin sores before we give our antimicrobial therapy with LA Bicillin. As I talked about, I haven't actually seen any cases of this, but there definitely are case reports, and talking to cardiologists in the past, there have been some rare cases where they've had to give anticonvulsants for someone with severe synonyms, chorea, and seizures. And in terms of carditis, it's a combined clinical and investigation assessment, and we use chest x-ray, ECGs, and echoes to specifically look and work out which valves are affected, what the LV function is, and whether there's any other complications like pericarditis or heart failure.
And this is from the RHD ARF guidelines, but carditis for me as a junior doctor always seemed like an elusive diagnosis. In addition to those investigation findings, the RHD ARF guidelines say carditis can present as a significant murmur, also cardiac enlargement, cardiac decompensation, as you said, pericardial friction, rub or effusion. Anosh, we've kind of talked all about the diagnosis of ARF and giving LA Bicillin as the best course of antibiotic therapy every 3 to 4 weeks, alluding to secondary prevention for ARF. Why is this so important and what is involved?
That's right. Yeah, it's a good question. Secondary prevention is to try and minimize acute rheumatic fever from progressing to rheumatic heart disease. And basically that's characterized, unfortunately, by recurrent episodes of acute rheumatic fever with the recurrent exposure again, unfortunately, to group A strep. And that can be, again, in the context of recurrent tonsillitis or pharyngitis presentations to skin sores and sort of secondary infections. The usual administration dose is 1.2 million units of LA Bicillin for those above 20 kilograms, and that's the adult dose, and it's half of that, especially pediatrics when they're less than 20 kilos. And the 3 to 4 weeks duration is because of the effect and sustained impact that it would have from a pharmacokinetic and pharmacodynamic perspective. The other thing is that, it is obviously trying to aid in adherence, but as I talked about before, because of the debilitating pain that some people can experience, it obviously is not looked upon favorably. But there are strategies we can use both non-pharmacologically and pharmacologically, such as lignocaine, around the area to try and minimize the pain when we give the intramuscular injection into the gluteal muscle region. We talked briefly about this before, but there's a different categorization and classification system of acute rheumatic fever, as we talked about with possible, probable, and definite. When there's no cardiac involvement with definite acute rheumatic fever, you treat it basically as a possible or probable ARF. And when there is cardiac involvement, then you would then think about looking at rheumatic heart disease severity, which has got its own priority system, which I'll talk about. If someone has mild rheumatic heart disease and they've got a documented history of acute rheumatic fever, thinking about treatment, that's 10 years or until the age of 21, whichever is longer, LA Bicillin. In terms of a moderate rheumatic heart disease patient, then you'd sort of be going up to 10 years after the most recent episode of acute rheumatic fever or until the age of 35, whichever is longer. And then just quickly on severe rheumatic heart disease, it's to 10 years after most recent episode of ARF or acute rheumatic fever or until the age of 40, whichever is longer. But like I said, I always look at the guidelines, especially when I'm in clinic seeing a lot of these patients. So it's something that I would urge you all to do as well. And if you're not sure, you have not only Melissa, as I said, who's our wonderful rheumatic heart disease coordinator, but you've also got a wonderful physician, human being, and cardiologist, and Dr. Angus Bauman, who is our main cardiologist here and director of cardiology at Alice Springs, who is fantastic and has witnessed and seen many, many cases of rheumatic heart disease and acute rheumatic fever over his time here in Central Australia.
You mentioned the different severities of rheumatic heart disease. What criteria dictates the severity of rheumatic heart disease, and what is the other follow-up required for those with RHD?
Yeah, that's a good question. And again, we can get into the intricacies, but I'll try and make it as simple as possible for those listening. So there is a priority system that's very important to understand when it comes to grading the severity of rheumatic heart disease. So priority 1 is those with severe rheumatic heart disease, and these include high-risk post-valve surgical patients, so those that have needed intervention in terms of replacement of the valve, whether that's a bioprosthetic or a mechanical valve, those have had repair, or those have had, for example, a balloon valvulotomy or a commissurotomy, for example, with mitral stenosis. So any of these patients are deemed high risk. The issue is rheumatic heart disease can still recur in patients who've had valve replacement because the underlying autoimmune molecular mimicry and disease process is still subclinically happening in the background. And so they're still high risk, and that's something which will be important because it will dictate not only the duration of ongoing LA bicillin, which is really the only thing that's been shown to obviously minimize this recurrence and progression, and also in terms of monitoring of echoes, specialist reviews, medical reviews, and dental reviews.
So anyone with a valve repair is priority 1 or severe RHD by default?
That's right. When we talk about severe valvular disease, we're talking about someone would say severe valvular regurgitation or stenosis. And just quickly, the two valves that are most commonly affected in rheumatic heart disease early are the mitral valve and the aortic valve, just because they're the systemic valves going out into the left ventricle aorta and systemic circulation. But that's not to say that the tricuspid valve and the pulmonary valve cannot be affected as well. So all 4 valves can be affected. And if you have a severe valvular lesion, as I said, whether it's stenosis or regurgitation, that comes in under severe rheumatic heart disease. Furthermore, with regards to pregnant women, regardless of the severity of their underlying valvular disease with rheumatic heart disease, they are automatically progressed or transitioned onto priority 1. And just going away again quickly from rheumatic heart disease and talking about acute rheumatic fever, LA bicillin is safe to administer in pregnancy. All right, going back, down to rheumatic heart disease and talking about priority 2 patients, that's essentially those with moderate heart disease, so moderate valvular lesions, it's, again, regurgitation or stenosis. And usually the early picture is that of a regurgitant problem just because of the degeneration and incompetence that happens at the level of the valve. And I won't get into the nuts and bolts of the fancy echocardiographic findings. However, over time, you do progress to a stenotic, tight, calcified lesion, and some people have mixed disease with both regurgitation and stenosis. Priority 3 is those with mild rheumatic heart disease. And again, the reason why we break it down to mild, moderate, severe is to dictate how often they have their follow-ups, their reviews. And then 4th is priority 4, or someone who's got a history of acute rheumatic fever with either possible, probable, or definite diagnosis and completed secondary prophylaxis. And borderline, just quickly, borderline rheumatic heart disease refers to those currently prescribed secondary antibiotic prophylaxis. They need a medical review in 1 to 2 years after diagnosis, and then they always need to be seen by a cardiologist before we decide about ceasing secondary prophylaxis moving forward. I know that sounds like a big jumble, and it probably is, but just important to know that there's different staging systems to grade the severity, and it's important because each stage or each priority per se in rheumatic heart disease has a different rate of progression to complications. And I think severe rheumatic heart disease with priority 1 patients over a 10-year period had unfortunately a 10% risk of death, just to give you an example. And so it's really important to try and minimize patients from getting strep in the first instance with primordial prevention, and then thinking about primary prevention from preventing group A strep leading to acute rheumatic fever, and then secondary prevention stopping acute rheumatic fever going to rheumatic heart disease.
Thanks, Anosh, for going through all the different types of RHD. What other interventions other than secondary prophylaxis and regular follow-up are there for those living with rheumatic heart disease?
Yeah, rheumatic heart disease, once it does happen, is not a reversible process. As I said, unfortunately, due to the underlying autoimmune molecular mimicry that is at play because of the group A strep infection. You can think about valve replacement, valve repair, or specifically for mitral stenosis, you can consider a balloon valvulotomy or a commissurotomy, where we're basically sort of helping open up a very tight stenotic valve and therefore improving blood flow between the left atrium, left ventricle, and therefore the rest of the cardiac circuit. Bioprosthetic valves is something that we do consider more so here in Alice Springs, and that's because of adherence issues with anticoagulation. It's something that's not ideal, and especially younger populations, we would definitely try and warrant mechanical valves just because they have a longer duration and as a result don't need redo stenotomies, which in itself carries risk, and therefore redo valves, but require lifelong anticoagulation with warfarin. And as we know with warfarin, it's not just about adherence, it's also about the lability in terms of international normalized ratio INR monitoring, and it's affected by multiple different factors, other medications, dietary changes. The last thing is to have a patient where we rush and give them a mechanical valve just because they're young and then have to deal with the complications if they become pregnant or if they then have issues with adherence. And that is a real disaster. And it's something that we do need to think about careful forward planning. And that's where the multidisciplinary team comes in to play. The other factors to consider, though, regarding valve interventions is about the age at the first operation. And unfortunately, as I said, rheumatic heart disease affects a very younger population, especially acute rheumatic fever, as I said, affects 5 to 14-year-olds, sort of namely women. So as a result, these people are having to live with valvular heart disease and its associated complications such as heart failure, pulmonary hypertension, and severe mitral valve disease. A lot of rheumatic heart disease you will see is associated with atrial fibrillation, the most common arrhythmia with rheumatic heart disease, and that's because of the significant mitral stenosis, but also mitral regurgitation, and the stiff left atrium that's not compliant and is also dilated. As a result, these patients are at very high thromboembolic risk, and we therefore need to think about whether they would need anticoagulation. And you may have heard of this when you're studying in medicine, but we think about AF as valvular AF and non-valvular AF. Valvular AF basically refers to anyone who has moderate or severe mitral stenosis, as per the European Society of Cardiology guidelines, whereas non-valvular AF is anyone with anything else and atrial fibrillation. And the reason that's important is because of the implications for management, and that valvular AF is normally treated with warfarin. There was obviously, and if you're interested, on a trial called the Invictus trial that looked at rivaroxaban versus warfarin. But in general, if we can, we try our best to sort of convince patients to be on warfarin. And 99% of world cases of mitral stenosis are secondary to rheumatic heart disease. So it's important, especially in our population, to think about anticoagulation. The contraindications, for example, very high falls risk, whether they're frail, whether they're elderly, whether they have uncontrolled seizures, whether they have other medications that's going to increase their bleeding risk. So there's a lot of things that you do need to take into account. And if you're not sure, always please ask for help and ask advice from your cardiology colleagues. Access to specialist follow-ups is also a complicating factor, like I said, because of the geographical boundaries, but also the language and cultural boundaries as well that we're sort of faced here. And whilst it is a challenge, it is extremely rewarding when we're able to work together and come up with a wonderful outcome for the patient as well as that community. Acceptability of redo surgery is not straightforward, and it's very complex, and that's why making that initial decision about which valve to do, whether it's even the right thing to do, is something that is a big discussion and normally involves 3 or 4 different meetings before we make that call. And the last thing I just want to quickly touch upon, just in terms of other complications of those living with rheumatic heart disease, about infective endocarditis prophylaxis. So anyone with rheumatic heart disease should get infective endocarditis prophylaxis. Obviously, some surgeries, especially more so than others. Dental procedures definitely would warrant infective endocarditis prophylaxis because these patients are very high risk. And if they get infective endocarditis on a background of rheumatic heart disease, that can really decompensate them. These are some of the complications and considerations when we think about the longer term aspects of rheumatic heart disease. But ideally, prevention is key.
And we are very lucky to have you, Anosh, at Alice Springs Hospital. You've been a wealth of information to all of the juniors, and also really appreciate you coming on for 4 episodes at Desert Docs. I know I'll be re-listening to this episode quite a few times to digest everything, and I hope the listeners find it very informative as well. Thanks.
No worries. Thanks so much, Indi, for this opportunity and for having me on board. I'm hoping that a lot of you guys will be at Alice Springs soon, and you'll be able to enjoy and reap the rewards of the wonderful life, not just in hospital, but also outside. Good luck.
Desert Docs, a junior doctor's guide to Central Australia, is an anti-health media podcast produced with the help of ACCC Studio.